Good morning, welcome into In the Trenches with DAC. Today I am going to be talking about lupus. This was the topic that was requested, and I'm going to give a short chalk talk on lupus. Lupus is a tricky disease because it can involve so many systems. Okay, point number one, positive ANA does not equal lupus. It can be associated with other conditions and a low titer, especially in an elderly woman, could certainly be a false positive. Okay, so lupus could involve so many systems. So you have acute lupus, subacute lupus, and chronic lupus. Chronic lupus really involves the skin, and it's something called discoid lupus, where you could have scarring alopecia and inflammatory lesions in the scalp and around the ears. Subacute lupus has different antibodies, usually an anti-Rho and an anti-La antibody. It does not, usually does not involve the kidneys or one of the more serious organs, more often the skin and the musculoskeletal system. What's significant with this, if a mother is delivering a baby and she has a positive anti-Rho antibody, she could have a neonatal heart block, and the baby might need a pacemaker. Most patients with lupus, well over 95%, are going to have positive ANAs. Subacute lupus has the same immunologic markers as Sjogren's syndrome. So let's talk about acute lupus. How do you diagnose it? So the classic way this was diagnosed until really, maybe 8-10 years ago was from a 1982 paper, the American Rheumatologic Association. And even though we don't use these criteria, you needed 4 of 11 criteria, it provided a way of looking at the disease. Okay, so number 1, a discoid rash, which you could also see. Number 2, a malar rash. So classically with lupus, you think of a malar butterfly type rash over the face in the malar area. Number 3, photosensitivity. Number 4, mouth ulcers. Okay. Number 5, renal involvement, and this is one of the more serious organs that's involved. And when do you suspect that? In this paper, it's proteinuria greater than 500 milligrams 24 hours, decreased complement levels, and abnormal UA to CAS. CNS complications, you could see a real myriad of CNS complications, from lupus cerebritis and confusion to aseptic meningitis to strokes. There are a lot of different types of CNS manifestations of lupus, and sometimes they're non-specific. Number 7, non-deforming arthritis. So the difference between this and rheumatoid arthritis, and the mnemonic is SLE, sublux easily. These people have arthritis and they have trouble, with pain and swelling, but they can move their joints. It's not deforming. Okay. Next thing is a positive ANA. Number 9 is serositis, so you can have pericarditis, pleuritis, pleural effusions, theoretically, although not as common as ascites, but you get serositis, specifically the pericardium and the pleura. Number 10, okay, you could have other antibodies like anti-Smith, anti-double-stranded DNA. I'm going to talk about the antibodies in a couple minutes, and I'm trying to think of the last feature here. We have the rashes, photosensitivity, mouth ulcers, renal, CNS, non-deforming arthritis, the biomarkers. I'm going to get back to that in a minute. Okay, but this was done before other things came out. So then there was criteria called the SLE criteria. Okay, which you had to have 2 clinical and 2 immunologic markers. And this, even more recently, this got modified by the Euler criteria. But the bottom line with this is that you have biologic markers and clinical features, and you need both of them. And that's the thing. One of the biologic markers is the antiphospholipid antibody syndrome. And that really, when this paper was being read initially, they had like a false positive RPR and all that. And that was actually antiphospholipid antibody syndrome. Now, what about the antibodies? So any double-stranded DNA, you see, it's associated with lupus nephritis. You don't see it with anything else. And anti-Smith is something you see with lupus, but not most of the time. Okay, most of the time it's not positive. Okay, any histone antibody is an antibody you can see with drug-induced lupus. And the drugs, people think about are hydralazine and proconamide, probably the most common drug that causes causes drug-induced lupus is minocycline, which is sometimes used for acne. That's really the most common drug. Sometimes complement levels could be used to assess organ involvement, especially with lupus nephritis. And with that, you're going to see a decreased C3 and a decreased C4. So these are the biomarkers, and then you'd get a lupus anticoagulant screen. The antiphospholipid antibody syndrome, about 50% of the time it's idiopathic, and about 50% of the time it's associated with a connective tissue disease, mostly lupus. Now, there's another very important point I want to talk about with lupus. A lot of people, especially young people with lupus, they develop premature atherosclerosis, and it's due to the inflammation of lupus. So you could have young women with lupus developing MIs or dying from MIs in their late 20s, and this is because of the raging inflammation, which is linked to atherosclerosis. And the other thing, there's this chronic lupus cerebritis, where often these patients, they have impairment in intellectual function, in judgment, in executive function, and it's due to chronic inflammation in the blood vessels of the brain. It's called lupus cerebritis. Another thing about lupus could affect most systems. Even though it's not in the diagnostic criteria, lupus could involve the lungs. You could have pleuritis. You could have pleural effusions. You could have acute lupus pneumonitis, acute inflammation. You could also have chronic interstitial lung disease, sort of like IPF. More often, it presents like non-specific interstitial pneumonia. And you could have pulmonary embolism with it due to antiphospholipid antibody syndrome. It could be associated with pulmonary hypertension. This would be Dana Point class 1. And it could also be associated with something called the shrinking lung syndrome, which is kind of a myopathy of the diaphragm where they have atelectasis. And that's something that's been reported. Okay, as far as the kidney is one of the most serious organs. And a lot of lupus patients wind up on dialysis and kidney transplant. There's 6 flavors of lupus nephritis. 1, 2, 3, 4, 5, and 6. 1, there's no change by light microscopy. 2, mesangial hypercellularity. 3, focal proliferative. I may have this one, 4, diffuse proliferative glomerulonephritis. 5 is a membranous GN, which you could get nephrotic syndrome. And 6 is chronic sclerotic. 3 and 4, diffuse proliferative and focal proliferative. Okay, these are the two things that need aggressive treatment and will be treated with steroids and possibly mycophenolate. And if it's serious, they're going to give them cytoxan. But these type 3 and type 4 are the two most serious features. Going through the other systems, so we talked about the kidneys. The kidneys and the CNS are the most serious symptoms you could have. That we talked about atherosclerosis. They could have serositis. They could result with pericarditis. You could get pleural effusions. To distinguish a pleural effusion with rheumatoid arthritis compared to lupus, with rheumatoid arthritis, you're going to have a low glucose. You're going to have a low glucose in pleural effusion. You could also have skin involvement. You could have vasculitis. Okay, in addition to the malar rash and discoid rash, you could have a leukocytoclastic vasculitis with a palpable purpura, with a small vessel vasculitis. Theoretically, lupus has been associated with pancreatitis. It's not a common cause, but you can still think of that. The lung involvement. The other thing that's important, there's a condition called mixed connective tissue disease, which early on is features of lupus and polymyositis. Later on, you get features of scleroderma. This is also associated with Raynaud's phenomenon, and Raynaud's, okay, it's something that's commonly seen with lupus. This would not be primary Raynaud's, it'd be secondary Raynaud's related to lupus, and you can get finger discoloration related to the colon. It could also be associated with sausage digits. Okay. The thing with this, the positive antibody is an anti-U1 ribonuclear protein antibody. This is with mixed connective tissue disease. Okay, this does not involve the kidneys. And classically, with drug-induced lupus, it does not involve the kidneys, and it does not involve the CNS. So, reviewing all this, lupus has a lot of different features. You know, the initial criteria, although they're not used to diagnose it, it kind of gives you an example of how many different features. The positive biomarkers in clinical, you have the skin involvement, the joint involvement, renal involvement, a vast array of CNS findings. You could have serositis. I got the last thing, and I missed this earlier. The 11th thing are hematologic abnormalities. This is in the 1982 ARA. So you could either have anemia, neutropenia, or a low platelet count. And these are immune mediated. Warm agglutinin, hemolytic anemia, immune neutropenia, immune thrombocytopenia, sort of like an ITP type picture. So you could also see that with lupus. That's part of the original criteria. Those are the hematologic properties. So theoretically, you could also get an anemia of chronic disease with lupus also. And with that, I'm going to stop. We are in the trenches, and today we talk about lupus. Done.